scaphoid view. Say, okay. So we're gonna do straight arm. And it is a 10 to 15 degree tube angle. 15 is always better. Anytime you have an angle range, the larger number will do the best job. I'm trying not to run you over. All right, now I'm gonna ask her to take her hand and only deviate as much as possible. Go out like that, other way, there we go. Set it down. I'm gonna put my central ray right on the scaphoid, which is right here, and the crack under your thumb. And I have plenty of room to collimate down. I'm gonna, see how my light is down here on the cassette? She's just gonna lift up a little bit and I'm gonna shift it to the middle of the cassette. Leave room for a marker.
Can you point where the scaphoid is on the
Scaphoid's right here.
And that's not too small?
What you're looking at is the size of my thumbnail.
Okay.
So that's actually really big, but if I go down to just that, I don't have room for a marker.
Yeah, just for comping.
So yeah, just leave room for a marker there.
And you said crack of your hand. Where's that at?
Your wrist
Where
crack.
hand bends.
Oh, this.
Wrist crack.
Okay.
So this is ulnar deviation, 10 to 15 degree tube angle. The ulnar deviation opens up the lateral side of your wrist and the tube angle will elongate the scaphoid. Beep. Now I ask her to do this and she says, it hurts, I can't. I said, all right, fine, leave your hand normal. We're gonna do no tube angle. I'm gonna take a 20 degree sponge and I'm just gonna slide it under her fingers, which arches her wrist. It does this, arches it. No tube angle, and I'm gonna put the central ray right on the same place. Get that out of the wrist.
What was the name of that one? I'm sorry.
Modified Stetcher.
Modified.
The first one was a PA axial, this is a PA not axial. It's called the Modified Stetcher. For her hands up on a stretcher.
But this is still seeing the scaffold.
Yes,
This is a scaffold.
it is the this is the non-preferred. The first one is the one we wanna do. This one's like, all right, we gotta do this one.
Without the degrees, right? But if the patient was uncooperative and couldn't turn her hand.
No, doctor knows. He knows what view it is. All right, oh yeah, the
Carpal.
goodie. All right, so it's uncomfortable for the patient, so you wanna get set up first. It's 25, 30, so I'm gonna do 30, coming your way. And move this way. All right, now she's gonna take her hand and flex it back as much as possible. We need the palmar surface perpendicular, which is pretty perpendicular. Now this pisiform and hamate are superimposed over each other, so we're gonna do a 10 degree internal rotation. Get my marker over there. Now this is our first tangential. So I'm gonna show you what a tangential looks like. You see right now, there's the crosshairs. So I'm penetrating nothing. I just want to skim, so I'm just gonna move this light field until it disappears. You see how that square disappeared right into her hand right here? It's very distorted right here because of the tube angle, but this is no good. Seeing it, just make that square gone.
It's right there.
Thank you. Like a blind man.
My glasses.
And we're not in the center of the cassette, so if you could just lift your hand a little bit. Move that so that square's completely gone. Yeah. There.
And what was the tube angle?
25, 30. With a 10 degree medial rotation.
Internal.
This
Yep.
is tangential.
It's the tangential, inferior, superior, or the Gainer Hart method.
When would you use 25 instead of 30? Or,
You wouldn't, they're just saying 25 to 30 would accomplish it, but the more angle always accomplishes it more.
so,
Could you
Always
just say
go
that
for the big
your
one.
target's in her palm?
It's 1 inch distal to the base of the third metacarpal, but yeah, palm.
Sure.
But I'm not even looking at that, I'm just looking at here and I don't see my square, so that means it's penetrating the hand.
Okay.
That was painful. Forearm, nice and easy. Alright, completely supinate your hand. We need elbow crack and wrist crack. Those are both on the cassette right now and in the middle, so I know I'm good. Her humerus is on the same plane as her forearm. And you're just checking, like, I've got wrist crack in the light, I have elbow crack in the light, I've collimated on all 4 sides. Beep. Now I need a lateral, so you're gonna turn your arm into a 90-degree lateral. I'm gonna shift my cassette, wrist up. Elbow's on there, wrist is on there, marker's on there. Just gonna cock that. Hey, getting hot.
Which position is this?
Lateral forearm
Level 4.
Oh, his hand's like this.
Oh, really?
until the end. Then it's not like that.
Okay.
But thus far,
Could you make a fist or not?
yeah, doesn't matter.
Okay.
Doesn't matter what this is doing. This just can't be like this.
Mhm.
Has to be up. All right, elbow. It's 10 by 12. We're gonna go straight out again. Put her elbow crack right in the center of the cassette. Make sure the hand is fully supinated. Show a collimation border on all 4 sides. That looks good. Right now, there is partial superimposition of the radius and ulna. The epicondylar plane is parallel to the image receptor. Nothing's really on profile. You can see condyles. Beep. New cassette. Now I'm going to take her hand and I'm going to roll in. And right now this should be 45 degrees. And because I'm doing an internal, this side's closest to the image receptor so we can see the trochlea and the coronoid process. Beep. New cassette. And take this arm, and I'm gonna start way on this edge of the cassette, and we're gonna roll all the way out until this gets 45 degrees. So roll, roll, roll. Stop. Marker there, readjust my leg. Beep. The external oblique puts the capitulum, the radial head, and radial tuberosity on profile. Did I say beep? Beep. All right, and then the next one we're going to do a lateral. Bend, bend, bend. Stick our elbow right in the center. Beep. This one puts the olecranon process on profile and the semilunar notch. All right, if she came in and her arm, sit up, was stuck like this, like that, try and keep it like that. It's stuck. I need an AP, but if I do it like this, I have now distorted this and distorted this. So I'm gonna do one picture with her, scoot your chair way back. Right there, and it's still the same centering and the same light field. But do you see how now my humerus is normal, but my forearm is not? So beep, new cassette, and then I'm gonna have you stand up. Lean in, get your head out of there, and beep.
So this one's 2 shots.
Mm-hmm.
What's it called again?
Partial flexion AP.
So one like that, and one like that.
Mm-hmm. Just because now this is good and this is ugly,
Mhm.
but the other one, this was good and now that was ugly. So we got an AP of both parts. We didn't get a good AP of the elbow joint, but that's all we could get. You can sit, be normal. All right, trauma axial laterals. I'm gonna take her arm and I'm gonna put it 90 degrees, and this is the only one pronated. We never do this on any other one, but this is for those trauma coil method. I'm gonna angle my tube 45 degrees. And that way, big toe. Oops, sorry, patient. So picture what we're doing here is, I don't like it there, I like it here. I am on her forearm, not on her humerus, and I'm kind of entering the coronoid process, but I'm exiting the radial head, and that's what we're looking at on this one, is the radial head. So imagine with a 45-degree tube angle, your CR is not going like that, it's going like that at 45 degrees, so just imagine I'm here, it's entering here, and it's exiting down there. So we're gonna see the radial head on that picture. Hold on, gotta grab something, hold on. Let me show you what it looks like on here, because it's cool, you can picture what it is. What arm is this? That's all right, crap, okay. Let me show you, lift out of the picture. So this is a different arm, but you can still get an idea of what it looks like. Thank you. Look over here. Do you see that radial head shadow? That's what you're trying to get it by itself, is that radial head. Remember the picture on the PowerPoint yesterday? Where the head was elongated, not by itself? That's this one. And the next one is the same thing, but it's for the coronoid process, not the radial head. So we're gonna take this arm again, put it here, but instead of 90 degrees, it's gonna be 80 degrees. Yep. This tube's still gonna be 45 degrees, but the opposite direction. I'm gonna run you down. So now my light has to hit that arm, so we're coming that way. Roll. Come with us. There we go. Head out of the way.
Right there in like the arm crack kind of.
Yeah, it's in the crack, so imagine now I got a 45-degree angle. I'm entering here so that I can exit there.
Mhm.
But it's pretty much right in the crack, and the other one was in the crack coming from the other direction. This one demonstrates the coronoid process. The other one was for radial head. This one's for coronoid process.
Which one's is this called again?
It's coil for coronoid process. Trauma axiolateral.
Trauma. Okay.
On comp, so you'll call it a coil? Or either one?
Either one. Mm-hmm.
That's why we stood.
Move your-